So what we here have on our slide is the AUA guidelines, Melissa, which actually very nicely incorporated the urodynamic findings and the urodynamic categorization of our patients with female stress urinary incontinence according to the treatment options. Can you please just tell us a little about it?
Yeah, it was very clear that there are special cases that we need to consider. And many of these, of course, are we have a concomitant surgical intervention, such as a prolapse surgery that you're doing with stress incontinence. If you have some other issue, such as a fixed immobile urethra, say from trauma or from prior interventions, or if you have lower urinary tract dysfunction that's neurologic in origin, and of course, the obesity in geriatric patients. These are all special considerations, and that we need to individualize this therapy. And this is really where shared decision making comes in, is that we need to help the patient understand what the limitations of our technologies are, and then choose the best thing based on their wills and their wants and desires and expectations for treatment. But certainly, with the ever increasing complexity of the patient population that we are all seeing, it is just critically important that we do the appropriate evaluation so we can give them the best outcomes first. We did get questions from the audience, and it's a very, very insightful question to find about what are the contraindications or limitations really to performing urodynamic studies in women with urinary incontinence. Do you have any?
Yeah, exactly. So this is actually very well reported also in the ICS, I mean, good practice papers and documents. And I would like to, suggest everybody to carefully read all these documents. One of these questions related to this topic was about the infection and about the risk of infection rate. I mean, do we routinely perform antibiotics? The answer is no. You don't have to perform or give our patients routine antibiotics. But of course, we have to check if the patient has urinary tract infection before the urodynamic study or not, and we can easily do it with a urinary dipstick to rule out urinary tract infection. And if there is symptomatic bacteriuria, this should be treated with appropriate antibiotic treatments. There's still discussion going on, but I know many centers do not perform antibiotic treatment in asymptomatic bacteriuria. So I think you can decide on this depending on the regulations of your local hospital infectious diseases regulations.
And other comorbidities of the patient, right? Other comorbidities of the patient. If there's some special case, if there's a renal transplant or some other immunocompromised, even if it's asymptomatic, we may choose for treatment in those situations. But in general, I would agree, we want to go as guideline based and with as much antibiotic stewardship as possible to only uh, treat symptomatic bacteriuria and to defer any type of invasive intervention if a patient is symptomatic. That's my one cut point always. I agree.
Yeah. And Melissa, as you said, we can differentiate between different, I mean, and patient, let's say, comorbidities in order to calculate the risk of posterior dynamic infection. For example, I mean, literature suggests that, for example, if you have patients older than 70 years of age, or with the history of recurrent urinary tract infections, or with patients with high post-voiding residual urines, or with vesicoureteral reflux, high filling pressures, I mean, non-compliant bladders, and for patients, as you said, like in renal transplant patients, under immune suppression, we have to be careful in these patients, and we may apply prophylactic antibiotic treatment for these patients. And what we have to do And without an exception is to obtain an informed consent from our patients. And we have to explain how the urodynamic study is performed, and explain why we are performing it and how we are performing it step by step. In my clinical experience, this increases the satisfaction rate significantly compared to patients who are not informed about urodynamic studies before the procedure. What's your experience, Melissa?
Well, I concur is that, again, this is a shared decision and it's a shared procedure and it's an iterative procedure. It's a living procedure. It's one where it is very important that everyone participates such that we get the best information from the patient. And the other thing is that we want it to replicate what's happening to them on a day-to-day basis, because sometimes there's some pretty significant urodynamic mismatch of what we may see on a urodynamic test and then what they're experiencing when they're not in our urodynamic suite. So it's really very important that we interact dramatically closely with the patient, just to be able to assess, is this actually replicating the situation, because we want to treat whatever situation they're having and not just a urodynamic finding.
Yeah, exactly. So it's not, infrequent that we find surprising findings, just sporting the saying that the bladder is unreliable witness. And so this again shows how important it is to objectively assess the lower urinary tract function and dysfunction. And urodynamic studies, no question, are the best objective tools in our hands to do that.